So good evening, everyone. Welcome and a big thank you for joining us on today's webinar, which is on tendon injuries with Dr. Jon Houghton. Today's webinar is brought to you by Steriplast in partnership with Basrat. Before we start, as always, we'll run through some housekeeping rules. Firstly, please introduce yourselves in the chat box. It's a great way for everyone to be able to see the different professions that have joined us today and where everyone is based in the world. Today's webinar will last around 40 minutes, and then we'll have time for any questions anyone has for Jon. Please pop any questions you have in the Q&A box throughout, and we'll try and get to all the questions. If you do see questions that other people have asked and you'd also like answered, you can upvote these by pressing the thumbs up, which lets us know the most popular questions and which ones to get to first if we do have a big influx. And then finally, everyone does get a certificate for today's webinar and the recording of this evening's presentation, and we aim to get these out within 2 weeks. Just so you're aware, this evening we'll be sharing a recording of Jon's presentation, but he will be joining us afterwards live to answer any questions at the end. So make sure we're still popping them questions in the Q&A throughout. So for those of you who are new to these webinars and don't know much about Basrat, I'll just give a brief overview on who we are and what we do. As always, apologies to those who join these webinars regularly and already know about Basrat. So who are we? Basrat are the professional association and regulator for sports rehabilitators and trainers. We provide regular CPD webinars for our associate members and registrants. So if you're in a healthcare profession and you're interested in being an associate member, please feel free to get in touch. It's £5 a month and the benefits are listed on screen. Thank you all again for joining this evening. I hope everyone enjoys the webinar, and a big thank you to Jon for giving up his time this evening. I'll hand over to Andrew to do a Steriplast introduction.
Thanks, Sophie. Evening, everyone. Apologies again if you've heard this before. I'm Andrew. I lead on our work in sport at Steriplast Healthcare. Steriplast is a medical supplier based in Manchester, and with over 30 years experience in supplying a whole range of medical equipment, as you can see there. We're really pleased to work in partnership with lots of teams from grassroots, professional, across different sports, different governing bodies, facilities, stadiums and clinics, etc. If there's anything that we can help with, obviously always welcome opportunity to help any other partners and customers. So please do get in touch and let me know if there's anything you need. If you could just move it on, please. So the Injury Rehab Network, we've been running for about 5 or 6 years now in partnership with Basrat, and the events have mainly been online since COVID. We get a really good sort of global audience, so thanks to all the people who regularly join the events from the UK and further afield. And we're obviously very fortunate to have some brilliant guest speakers who kindly sort of share their time and expertise and insights from their work. All of the events that we've got this year, you can see the topics listed there. The next event is on the 7th of July with Dr. Jon Rogers, and he'll be talking about management of bone stress injuries. So please do have a look out for that one and get involved as well. As Sophie said, Jon has kindly managed to do a recording because he's otherwise engaged at present, but he will be joining the Q&A live. So I hope you enjoy the presentation, and thanks, Jon, for kindly helping out. I'm sure it'll be an interesting topic, and it's a topic that we haven't covered before. So thanks very much.
Just getting the recording up now.
Good evening. I'd like to thank Andrew and Bazrat for inviting me to give this webinar this evening on the management of Achilles and patellar tendinopathy in the elite athlete, and really asking some of the things that we've learned from treating a lot of elite athletes over this last decade in our Fortius Tendon Clinic. I'm Dr Jon Houghton. I'm a consultant in rheumatology and sport and exercise medicine, and I've been with Fortius since 2016. And really, right at the start, I need to acknowledge my colleagues here, because this is a team event. This isn't an individual presentation. I've been working with these guys for a long time now, and Jarrod, Sam, James, Sanjay, and Johan have been integral to the development of this clinic and our thinking, and bringing together all of our insights to really maximise how we're treating our elite athletes today. And I think the key is that we can all learn something from the elite sport world and take that across into our standard management. And that's often how some of these developments in surgery or medical management occur. So just to go through
Apologies, everyone. Seem to be having just a bit of a technical issue here.
an intro and some aims. So I think the difficult and high demand tendons definitely need an MDT approach, and you need a whole team of people all the way from sport and exercise science, sports therapy, physical therapy, SEM, surgical, radiology to get the best out of this. Then I'm going to talk a little bit really about the risk factors that sometimes we overlook a little bit, and then introduce you to a novel technique called ultrasound tissue characterization, which my colleague Jarrod Antflick has done a huge amount of work with, probably more experience in the world than anybody at this particular type of imaging. Talk a little bit about loading, and then I'm going to give 3 case studies from elite sport, and then really go through some of the more exciting new surgical options that we've got at Fortius Clinic through this service. So I think the first thing that really frustrated me right from the start of getting involved with tendons was that it's not one size fits all. And even when you look at literature around Achilles tendinopathy, some papers don't even differentiate between an insertional and a mid-portion Achilles tendinopathy. And for me, this is fairly criminal. I think that there are huge differences, and in my brain, I'm thinking always about what's the differential diagnosis here, what's driving this particular tendinopathy, because they're all very, very different. And just simple examples with the Achilles, is it insertional or mid portion? Is this a mechanical overload, or is this a de novo presentation of an inflammatory disease? Is this a typical overload, a middle-aged athlete who's doing too much without the strength, or is this a metabolic problem in someone who's not overly stressing the tendon? Are they athletic, or are they very sedentary? And these are very, very different diseases in my mind. And I think that this was one of the reasons I was really excited to come to Fortius in 2016. James Calder was fairly integral in that, wanting me to get together with Jarrod and set up our tendinopathy service. So what do we offer? We run a weekly clinic, which is myself as consultant in sport and exercise medicine and rheumatology. We have Jarrod Antflick, consultant sports physio. We have a very structured approach to our history taking. We're using some fantastic imaging techniques, and normally at the end of each clinic, each patient will have a diagnosis. They will have a loading program and a plan from A to B to C of what we're going to do to try and intervene. Obviously, then we utilise our surgical colleagues when we're failing, or sometimes straight off the bat if we feel that that's going to be the most appropriate thing. I'll talk a little bit more about that later. So just thinking about a differential diagnosis for the Achilles tendon, and I think this was one of my earliest conversations with Chris Myers and Jarrod and myself, and we were just sort of really frustrated that everybody was treating everything the same. And this is what runs through my brain, certainly, whenever I see somebody with posterior ankle pain, you know, taking out all of the posterior impingement, etc. But anyone with an Achilles problem, these are some of the things that are going through my brain as to what could be driving this. So A, is it insertional mid portion? Then is it a mechanical problem? Is it an intrasubstance tear? Is it inflammatory? Is there a Haglund's and a bursal involvement? Looking at the mid portion, is this a mechanical problem and quite diffuse, or is it diffuse and metabolic? Is it more medial biased, where the plantaris is related, and a lot more about that later? Or is it in the ventral surface, the superficial surface, or the paratendon? Because they all behave very differently and have different patterns of pain. Intrasubstance tear is probably the one thing that has really changed practice in this last probably 5 years, certainly since COVID. We saw a whole raft of these, and more of that later. And then indeed plantaris rupture or tendinopathy of itself. And I'm not really going to talk about complete tears of the Achilles because that's a separate thing. So taking a wider lens on the history. So the typical questions are always about training load. Has that changed? Volume and intensity. I think a key thing in the elite sport is, was there a moment? And again, in non-elite sport, that's probably relevant, but we see a lot more intrasubstance tears in the elite athletes rather than recreational athletes and runners. So was there a specific moment? And then I will also want to ask the less typical questions, thinking about the differential diagnosis. Is there an inflammatory problem going on here? Have they had a preceding GI-GU infection? Is psoriasis a problem? Is there any spinal involvement or family history of inflammatory arthropathy? And then thinking about metabolic issues. Have they used fluoroquinolones like ciprofloxacin previously? Do they have raised cholesterol, gout, diabetes, thyroid disease, or peri-postmenopausal, which again is something that is becoming increasingly apparent in our practice? So thinking about the inflammatory side of things, anybody with significant morning stiffness greater than 30 to 60 minutes, one should be considering the seronegative arthropathies as a cause for an insertional Achilles tendinopathy. I think that most people with Achilles tendinopathy will have morning stiffness, but it's often 5 to 10 minutes or so. So asking about psoriasis, asking about nail problems. Psoriasis tends to hide in places like the scalp, the belly button, and the butt cheeks, or the tip of the penis. So these are places that we don't like asking about, but I tend to because it gives us a lot of information. And the number of times that somebody says, oh yeah, well, I've got psoriasis, when they've seen 2 or 3 people already, I can't count them anymore. So I'm asking about inflammatory bowel disease, inflammatory eye disease, family history. Do they have an excellent response to anti-inflammatories, and especially in the insertional? So psoriasis can come in many forms. It can be typically on the extensors like the knee and the elbow, or it can be more guttate like the picture in the top left. It can affect the nails. Often we see dactylitis, which is inflammation of a digit, typically the toes. And again, for most sports people, they will just put that down to, oh, I must have knocked my toe, or I must have got a kick on it, but this is an inflammatory problem. And in the bottom right, this is some psoriasis in a scar, something called Koebner's phenomenon, and some inflammatory eye disease on the bottom left. So I think metabolic factors are becoming increasingly important, and that's probably because we're getting increased participation as people get older. The benefits of exercise are much more apparent now, and people are generally getting older anyway within the population. And I think we're getting increased female participation, which is really, really important. And I saw a huge swathe of increased tendon injuries when I used to have my practice in Kent. With some of the local running groups that got together specifically for women. They tended to be in their late 40s and 50s when the children were a bit older, and there was just a raft of Achilles, patella and hamstring tendinopathy. So things that we're thinking about: high cholesterol, high uric acid, poor sugar control, low estrogen. All of those things will adversely affect how the tendon responds to loading. So my typical inflammatory metabolic screen would be an ESR-CRP and HLA-B27. We routinely check cholesterol, triglycerides, glucose, HbA1c, uric acid, thyroid function, and a female hormone profile if we think that there is an inflammatory or metabolic component. So what about our imaging techniques? And ultrasound has been around for decades now, and for the last 20 years or so, most sports and exercise medicine doctors have become skilled themselves in utilising ultrasound for tendons. And you can have a good look at the tendon, measure the AP thickness, which is important, look for areas of hypoechogenicity, where there's more matrix fluid and breakdown of the collagen, and also look at neovessels, which is a marker of a chronic pain type response. One of the things we've been lucky though is with UTC imaging, and when I first met Jarrod and Chris Myers previously, they had a UTC scan and were getting some really good insights, and my work with Jarrod over the years has really harnessed my thoughts on this, and it's a real integral part to my practice. I know several other sports doctors who aren't convinced that it changes things, but I'm 100% convinced from doing this now for a decade. So it's an ultrasound probe still, but it takes multiple images and then puts them together in a single image with 3 different views and a combined sort of 3D view. What we then look at is what are the echoes coming back to the UTC, and it grades it into 4 different echo types, which essentially looks at the echo structure of that tendon. What I really like about it is not just that it helps within your differential diagnosis, but you can monitor tendon structure and discriminate between those various pathological states. So it's essentially an ultrasound on a tracker that moves, and you can see Jarrod just placing it on the ankle here. He holds it very still, and then it takes an image over 10 to 12 seconds. What does it all mean though? So what we want to see on the scan is lots of green and blue. So mainly green, a little bit of blue. So that's well organized fibers. When we start to see fibrillar nature, we're getting a breakdown in that collagen and the matrix. And a type 4 fiber is where you're not really seeing collagen fibers, so you've got complete breakdown of the tendon tissue. And how do we use it? Well, it's helpful for our differential diagnosis. It helps us for our surgical planning, more of that later. Jarrod will adapt his rehabilitation depending on that differential diagnosis, and it's also good for monitoring. So it has meaningful change over a period of time, whereas MRI and grayscale ultrasound much less so. Often a tendon will look after a year or so of problems, even if symptoms have completely abated. An MRI and an ultrasound may look exactly the same, still a thickened tendon, but the UTC gives us a much better idea of the overall quality of that tendinopathy. So this is probably a key slide for me, and I love this slide, just looking at what are some of the UTC patterns that we're looking at. And you can see, starting from the left, a fairly normal tendon, primarily green and blue. We then look at an insertional tear, the next one along, and you can see the big areas of red right up onto the insertion there, and our 3D view gives us an idea of that. Plantaris, which is a key player in athletes, gives us a very typical medial-sided redness where the rest of the tendon looks really healthy. We're then looking at an intrasubstance linear tear, a paratendinopathy, and then a tear down in the ventral surface of the mid portion. So a little bit on tendon loading. I think this can be quite controversial, but the basic premise is that we're trying to produce type 1 and type 3 collagen from physical loading. What are the tendon types that we can use? So there's a lot out there in the research about isometric, should it be eccentric, concentric, combination of both. I think my take on this is probably that there are elements that don't matter as long as there is some heavy and slow component to that loading. And certainly in the early stages, I tend to avoid loading in compression. I tend to rationalize this to patients by saying, don't stretch and don't squash your tendons. So again, if you load in compression early, that can lead to both a squashing and a stretching of the tendon at the same time, which it doesn't tend to like. So what about isometrics? And Emily Rio published this paper, which has hugely influenced rehabilitation for many people, where they showed that a heavy 45-second isometric was much better than a eccentric concentric exercise in reducing pain. Now, the critics of that particular paper would say it was only 6 players, so very small. And other people have tried to recreate that work and not found the same responses. So I think that there's quite a few people in the tendon research world who would say that the isometrics don't give quite the benefit that Rio suggested in the initial phases. From my personal experience, I think there are lots of players who do use it as part of their pre-activation and do get some pain response from it. So I think it has a place. So heavy and slow is the way to go, and this is a great paper, one of my favourites, from 2009 from Kongsgaard. So this was looking at steroid injections versus typical Young's eccentric decline squat versus heavy slow resistance. So heavy and slow is the way to go, and this is a great paper, one of my favourites, from 2009 from Kongsgaard. So this was looking at steroid injections versus typical Young's eccentric decline squat versus heavy slow resistance in patellar tendinopathy. 3 groups. Heavy slow resistance showed the greatest improvement and satisfaction at 6 months, and typically the steroids were great at the 6-week point, but back to square one at the 6-month point. And I'm a big fan of avoiding steroids in tendinopathy if at all possible, especially in professional athletes. I've seen too many things go wrong in terms of steroid atrophy, fat pad atrophy, depigmentation, and worst of all, tendon tear and tendon rupture. So it's very rare for me to inject steroid around a tendon. And this heavy slow resistance has taken on, and this is pretty much an adaptation by Kongsgaard and his team for the Achilles tendon, which showed good improvements. Some of the other adjuncts that we use, Jarrod's a big fan of using different foot positions. with high force isometrics as part of our Achilles loading tendon program. And we also use quite a lot of blood flow restriction, especially in people who are weak or post calf tear or post surgery where they've got reduced calf mass. So I'm just going to go through a few little case studies. The first 24-year-old international footballer had calf tightness, and an MRI had showed tendon thickening and a paratendinitis. Over about 10 days, his lateral calf had got progressively worse and had to come off during a game due to increased pain. What we had from the club was that there was diffuse swelling clinically to start with, and when we saw him in the clinic, unable to undertake a single heel raise. In a young patient or an athlete, this is a big red flag. If they can't undertake a single heel raise due to pain, that normally does suggest a significant intratendinous lesion, even if the tendon is intact. He could double leg heel raise, but that was pain of 5 out of 10 and very tender through the lateral column of the Achilles tendon. So this is the grayscale. And again, this is a key thing that I've learned matching UTC to all of my grayscales over 10 years. And I've got much better at grayscale of tendons because of being able to retrospectively look at what I'm seeing with a UTC scan afterwards. And you can see in this top right corner, it almost looks as though someone's licked their finger and just smudged the bottom of the tendon. It looks fairly indistinct, whereas you've got more fibrillar pattern above that. In the axial views, you can see the plantaris just off to the side, more of that later, and an abnormal portion in this section and this section here. So UTC scan, and again you can see that this is 3 different views of the tendon, axial, transverse, longitudinal, and then a complex 3D view. And we can see just on the grayscale that I was seeing, basic grayscale on the UTC scan showed this area of ventral lateral abnormality. We then add the colour to this. So now what we're looking at is a lot of green and blue within the tendon, which is good, and then we start to see red within the ventral aspect of the tendon more distally, and as we come more towards the myotendinous junction, it moves laterally towards that lateral MTJ. So the diagnosis here was an intrasubstance lateral column partial tear. Now, I think without UTC, that's a lot harder to be certain that this is the diagnosis, but we have a lot more confidence given that diagnostic involvement. So our plan for this was a small volume PRGF injection at 3 points a centimetre apart through that linear tear. And the reason we use small volume is that I'm not a big fan of large volumes of PRP or PRGF, as they can create quite a lot of increase in inflammatory tissue in the acute stage, and we're trying to avoid that to some degree. They go into a boot for 10 days afterwards, and then they have a fairly moderate program coming out, progressing to heavy and slow. And this particular player was seen at 8 weeks, had good strength diagnostics, and had a 2-week graduated return to full team training. But that's the sort of duration of time it can take for these intrasubstance tears, often 10 to 12 weeks for a complete resolution. If they keep training on it, they'll eventually get to the stage where they can't play. Second case, 29-year-old international rugby. So 6 weeks of progressive mid-portion Achilles pain. Morning stiffness borderline at 30 minutes, so quite a lot, and would have pain post-training and games. He got to the stage where he couldn't actually train or play following an international. Now, this is probably the difference between rugby players and the rest of humanity, but pain was 3 out of 10 at worst and 1 out of 10 average. So his 3 out of 10 was stopping him training post an international game. Now, on here, what we can see is on the MRI scan, plantaris adjacent to the medial column. And this is a typical thing that you may see in the acute stage where there's high signal within that medial column. Now, the plantaris is an odd thing. It does nothing. It comes from when we used to hang upside down in trees. And there are a number of insertions that are there that we can see on ultrasound. Now, most typically a type 1 medial insertion quite close to the Achilles tendon, and there's normally a clear border between the two. Type 2, it tends to stay well away before it attaches to the calcaneus more distally, and we don't tend to see so many problems in those athletes. In type 3, there can be a posterior insertion or ventral insertion there, or a type 4, there's no clear separation, so it merges with the Achilles, and it's in some of the really difficult cases it can be invaginated into the medial portion of the Achilles, which is a much more tricky combination to deal with. And Marvin Ye did a load of work with us on MRI and mapping, and you can see here that when you're in 20 degrees of flexion, that's when the plantaris tends to come into touch with the actual Achilles tendon, but when you're in neutral, it's sitting further apart. So what's the effect of that plantaris? Well, it has both a compressive and an irritable effect. It creates inflammation, less capacity for elongation, and then often you get adhesions, and this is when you start to get real problems within the tendon itself. So what do we see on grayscale ultrasound? A thickened mid portion on the medial border. We can see the plantaris here, and we can see near vessels in the interspace between the plantaris and the Achilles itself. What does the UTC scan show for these? So again, on the grayscale, we're getting a few clues. And typically with grayscale, tilting the probe will give you some good information, but it does change the color. So one has to be relatively skilled to be able to interpret what is anisotropy of the tendon or what's genuine pathology. The UTC scan kind of takes that out. And we can see on here on the axial views, you're seeing this typical crescent of red within the medial column, mainly dorsal. And again, there's some good evidence going back to 2006 suggesting that the UTC can show this plantaris effect on the medial tendon. What does the UTC echo profile look like? So normal tendon on the right here, lots of green, lots of blue, tiny amount of red and black, that's acceptable. This is the pathological tendon, lots of red, lots of black, and we can map this over a period of time and see where in the tendon there is meaningful change. So what did we do with this player? We used triple therapy, and a little bit more of that in a moment. So etoricoxib, doxycycline and omega-3. This is my favorite mix of triple therapy. And then we did an Ostenil Plus injection between the plantaris and Achilles interface. And again, this is a really favorite technique of mine, to go in with a tiny orange needle and just put that layer of Ostenil Plus between the two tendons to reduce that compressive friction, inflammatory mediated response. In terms of the drug therapies, we know from Fallon in 2008 that anti-inflammatories in the early stages do have a benefit. So they both inhibit tenocytes and aggrecan inhibition, and that's with a number of different anti-inflammatories, and often a simple over-the-counter such as ibuprofen can be helpful. Tumor necrosis factor is a pro-inflammatory cytokine, and anti-TNF is one of the main targets in rheumatoid arthritis, but doxycycline is an antibiotic that has anti-TNF properties within tendons. It's quite a mild antibiotic. It's often used for chronic skin inflammation also, so there's less concerns about longer term use. And it also inhibits some of the matrix metalloproteases that are breaking down the tendon in that acute phase. So Fallon's initial polypill was just ibuprofen, doxycycline, and then either green tea extract or omega-3. We tend to use a much stronger, selective anti-inflammatory and omega-3 pure EPA, which tends to have slightly better benefits than the DHA cousin. So this is just a few images from the injection. You can see up here plantaris on the axial. Here's the Achilles here coming up to the MTJ. This is post-injection. So this is the layer of Ostenil that I've put between all of those. And you can see in the dynamic view, here's the plantaris off here. So I've separated it well away from the Achilles with that layer of osteonyl, and that just buys the tendon a bit of time to calm down, reduce pain, and then you can start to load them. This is a typical program that you might see from Jarrod if you've sent patients through our clinic. So this is his calf Achilles tendon loading program, and you can see that there's a number of exercises, normally done 3 times a week, never on consecutive days, and both single leg bent knee calf raise, high force isometrics using Nunez's variable foot position, and a standing single calf raise also. Often that might finish with a standing double leg calf raise with blood flow restriction. And you can see that what he's done here is taken the Kongsgaard program and the progressions of intensity, i.e. a 12-week program, and you can see it starts off with 4 sets of 15 at around 6 intensity, and then by week 3 to 4, 4 by 12, intensity going up, 5 to 7 weeks, 5 to 10, then 5 by 8, and you end with the 6 by 6 at 8 to 9 intensity. So that's when you're really pushing the really heavy weight, and you should see a very progressive increase in that weight over this program. Case 3, a European Tour golfer, 3 months of insertional Achilles pain. Variable morning stiffness, but often very sore at the end of the round. Now, I'd seen this particular player previously for a B27 related sacroiliitis, so already my warning signs were up for an insertional Achilles tendinopathy. If we have a look at his standard ultrasound images here, we can see that his insertion is really quite thickened. At the top here, we can see an erosion pit at the insertion, again typical for insertional inflammatory. We can see a bursitis and lots of neovessels throughout. What did we do with him? Again, we used high dose anti-inflammatory, but for a more prolonged period, so 8 weeks instead of 2 to 4. We did use the doxy. We were using medicated plasters overnight and everything to really suppress that inflammatory response. And then it was a slightly more modified loading program, which wasn't quite as heavy. It was more moderate and then progressing to heavy. So we're taking a slightly slower, prolonged course with somebody with inflammatory problems. And I think that certainly a lot of the non-elite athletes that we see who've got the more metabolic tendinopathies, this is probably the way forward, to start with quite light, then move more to moderate, and only if they're tolerating an improvement going to heavy, slow loading. So what happens when we can't fix them? Now, certainly the vast majority of non-elite athletes or non-elite standard patients will not need surgical intervention for their tendinopathy. But at the elite level, we are seeing more and more that are getting larger intrasubstance tears or significant impairment that's affecting their ability to play and earn their money and their contract within professional sport. So this is often where the surgeons come in. And I'm borrowing some of James Calder's slides here regarding plantaris release. Now, we talked about the plantaris a little bit earlier, and we've got Huck and Alfredson really to thank for the vast majority of work that was done through this sort of work. And you can see that he is using fairly large incision just there to explore the tendon, debride areas of abnormal tendon, and then to take away the plantaris. And you can see that most people did better with those early operations, but you're still talking about 5% or so giving up from professional sport because of that recurrent tendinopathy caused by the plantaris. Now, this is a great slide to show how the plantaris and the Achilles can annoy each other, and you can see the amount of change within the Achilles tendon there, whereas the plantaris, which is a stiffer tendon, almost works as a garrote. Now, on these two images, you can see that the two are apart most of the time, but as you get into that end of range, then the two tendons do converge and come together. Now, if they're very close together, you get this garrote type impingement of the plantaris, which is stiffer going through that medial column, which can cause significant inflammatory change. So is it a clinical problem? And my great friend Noel Pollock published a decade ago on the UK athletics athletes. So over 214 athletes over 4 years, 83 of them had Achilles tendon problems. So yes, it's a big problem for professional athletes. And about 40% of those were diagnosed with plantaris being the primary issue that was causing that tendinopathy. And a significant number of the sprinters would have a unilateral plantaris issue depending on their bend run. And a number of them, out of those 33, so about a third, ended up requiring an excision to continue their sport. So these days it's a mini open excision, and these are James Calder's intraoperative videos, and you can see that he'll have all of our UTC images and ultrasound well before the surgery. So makes a small incision, you find the plantaris, and you can see there that he's just debriding a small amount of the adhesions away from the plantaris and from the Achilles tendon itself. Once you've cut the end, he then advances that further up the calf, then makes a further incision where you can cut the plantaris more proximally and remove the entirety of that plantaris. And I think that certainly in the very early stages we did have the odd complication where just the small area down by the tendinopathy was removed, and then you'd have a recurrence of scar tissue, etc. But James now takes a large amount of that plantaris away, so that reduces that compression and inflammation that the plantaris tendon is causing, and you just get a stump that's left up in the MTJ, and hopefully that doesn't cause a great deal of difficulty. Then he'll just again look at any adhesions around where the surgical bed has come from, where the plantaris has been attached to the Achilles. As I said, there are some where it's completely invaginated, and those are the really difficult ones, as the surgeons need to dig in more to the actual tendon itself, and so they tend to take longer, with more problems of paratendinopathy or inflammatory change later on. So does it work? Well, certainly the two small papers in Elite Athletes would show that. James's series of 32 professional athletes, 30 out of 32 returned to sport on an average of 10 weeks. And the more severe the tendinosis, the worse result. And again, those were the ones that I was just discussing, where the plantaris is embedded in the medial part because it's just cut through over a period of time. But what about the patella tendon? And I'll be very honest, Kongsgaard paper was fantastic, but for quite a few years, myself and Jarrod were really frustrated with the patella tendons because they were very, very slow. They don't respond to mechanical loading quite as quickly as the Achilles tend to. You can get some meaningful improvements within 2-3 weeks on the Achilles. Often it's 6 to 8 weeks with the Kongsgaard patella loading program before you even show a benefit, and it's quite a hard program. So for patients, that's difficult if they're 8 weeks in and don't really feel that they're making much progress. In terms of the other adjuncts, we've used ESWT and also played around with PRP and PRGF over the years. But again, I must admit that my experience with those and with nitrate patches also has not been hugely encouraging for the patellar tendon. It's a real long recovery if surgery has been thought about or undertaken. And I think, quite a few years ago, we worked closely with Sam Church on some of these difficult tendons in elite sport. And the three of us were really just quite frustrated with how slow it was and the results we were getting. So what about PRP? There's 2 randomized controlled studies, both quite small, only about 8, 9, 10 people in each group. One showed no benefit over saline, but they were using rehabilitation alongside it. One did show a clinical benefit with leukocyte rich over leukocyte poor or sham saline. So both RCTs, differing results, but small papers. And really the problem facing the surgeons is that the evidence was really quite poor. So Cochrane database in 2019, uncertain if surgery is beneficial over therapeutic interventions. And it really was your last straw, last dance, last chance. And I think one of the key things, certainly when we started looking at this, Sam did the PubMed search, 160 hits combining patellar tendon and surgery. Now that sounds a lot, but actually it's not a great deal at all. If you've ever put anything into PubMed, it's normally thousands. And just if you put ACL and surgery for reference, 26,000 compared to your 160 on patellar tendinopathy. So what did the literature say? And here's just 6 people giving their particular surgical approach and how they would do that patellar tendon surgery, all different. Using arthritis, you add in the more recent ones, now we've got 12, 15 different surgical approaches. And whenever you see this, it means that nobody really knows and there is not an outstanding winner. So what about using arthroscopic, minimally invasive ultrasound guided tendon debridement? And again, we've got Hakan Alfredson and my friends Lorenzo, Brad and William, who have all been involved in this paper in 2020, where they took 23 people, not necessarily athletes, but primarily just recreational sports people, and showed that they could improve patellar tendon pain, function and structure in those with persistent patellar tendinopathy. So this was really the thing that we wanted to try and recreate through our tendon service and just make some tiny adaptations to it. So what we started to do within the tendon clinic was make some specific measurements, and you can see up here where we're looking at more normal tendon up in the upper part of the tendon. So this is the patella just here, and it's normally the superficial, which is more spared, and this deep surface just underneath the pole of the patella, which is highly abnormal and dark. We'd then look at neovessels, and importantly, we'd look to see, is there a lot of superficial neovascularity, because that will affect the type of operation that we would do. So some pre-surgical planning in terms of looking at specific measurements and knowing how much tendon is normal. We then map that onto the UTC, and again, you can see that the deep portion is normally the most affected, with a more normal crescent of tendon above that. So pre-operatively now, Jarrod started going into theatre with Sam, reassessing the tendon, making sure we got all of our planning and neovessels. And then you can see here, this is just some intraoperative footage. So Sam, under ultrasound guidance, Jarrod is guiding him to the area that we've already agreed that we're going to take away from the tendon. And you can see that he's using a shaver to take away the abnormal tendon at this area between the junction of the fat pad. So utilising that shaver, taking away only abnormal tendon and leaving as much healthy tendon as possible. What Sam would then do is just release the fat pad from the tendon without excising it. I have seen a few problems with when you start excising fat pad with increased scarring or serous collection, and then debride that patellar tendon with the synovator. And often if there was an inferior pole that we felt was impinging on the tendon, then that would be decorticated. But the key was taking as little bone as possible, rather than many of the typical open surgeries that involve drilling into that inferior pole. And this is post what that debridement looks like. We've taken all the abnormal tissue from here. This is just the fluid from the arthroscopy at the time, casting this large acoustic shadow, but trying to leave as much normal tendon at the top. And then a tiny mini open excision on the front of the knee. I'm not sure if you can see from the slides, but it all looks a little bit brown and yucky on the front here. That's all debrided down to shiny tissue. So we're taking away some of the near vessels, scar tissue, nerves away from the superficial aspect of the tendon. These are unpublished results and a little bit out of date now, but 34 cases to date. I think we're up to about 45 now. We've done over 15 professional athletes in football and rugby and athletics. All patients have improved significantly apart from one. We had a mean pre-op Visa-P of 53, and the mean at 12 weeks was 82, and 6 months 87. In our elite athletes, we've had return to play times falling primarily between about 10 but more towards the 12 weeks. But compare this to typical open surgery, which is quoted as 5 to 6 months, where often I see a lot of real post-inflammatory change and real difficulties. So significant time cutting here, which is key for elite athletes. I think the other thing that working with the surgeons has really taught me is thinking about the secondary causes. And nowadays we look for patella alta in all of our patients because this is a big cause of secondary tendinopathy or patella tendon conflict syndrome, which I think was not particularly on my radar till we started working so much with Sam. And you can see on this MRI scan a long high tendon with the tendinopathy impinging on the lateral femoral condyle. And so what we typically do now is a series of tendon x-rays to look for patella alta, and then if there is patella alta, then we'll combine this with ultrasound guided patella tendon debridement. But Sam or Sanjay will also do a tibial transfer. So the tibial tuberosity is transferred downwards to bring the knee into a much more favourable position. So really just to summarise and reflect, difficult high demand tendons do need an MDT, and I think over the last decade I've been lucky enough to work with some great people who are really clever and wanting to try and improve the outcomes here. I think from my perspective, you need to keep your differential diagnosis wide, and my rheumatology hat always is on when I look at these patients also. I've had huge benefits from UTC, but for the vast majority of the public, loading is the absolute medicine that they need, and if you get them early enough and get them on the right loading, then they will do well. Loading is key for elite athletes also, but we know that there's lots of other time pressures, and we've developed a number of techniques over this last 10 to 15 years, which I think are really, really helping some of our elite athletes. Now, as I said, some of this may well start to appear in your non-elite athletes, and we're already doing the ultrasound guided patella tendon debridement on non-elites who are finding significant benefit from it. So once again, I'd really just like to acknowledge my team, James Calder for bringing me to Fortius Clinic all those years ago, Jarrod, who I've been arguing with for the last 15 years, always healthily, and our disagreements often lead to us thinking about things differently, and we challenge each other and push each other to get the best. Sam's been fantastic, just being really open as a knee surgeon to admitting that maybe they didn't know what was best and was open to trying new techniques, and that's really forged the way for Sanjay, and similarly for Johan, who we're working increasingly with around some of the elite sport Achilles tendon work. All fantastic colleagues, And many thanks for listening this evening. Hopefully, I'm going to be online shortly to answer some of the questions that you may have. And that's just my contact details. I'm happy for you to contact me on my personal email up there. I run clinics at 75 King William Street, but also at 66 Wigmore Street. And you can book into the Tendon Clinic any of your patients that you think would benefit. Many thanks.
Thank you so much, John, for that presentation. Apologies to everyone on my behalf for the technology at the beginning, but I think we got there in the end. So lots of good feedback already flowing in for you there. So thank you very much, just to begin with. We've got some questions in the Q&A. Are there any in particular? I know time-wise for some people they might need to nip off, so I do apologise, but is there any from your side, John, that you think would be useful to answer?
Yeah, thanks very much for joining, and hopefully it's been helpful for people. And apologies that you had to watch a recording. I managed to double book, unfortunately, so I'm working this evening, Surrey, and so I thought I'd better record things and keep my time online as a minimum. There's a couple of questions on ESWT. I think those are excellent questions. I certainly, when I was working with the military in the early 2000s, we were using ESWT quite early in the UK. And I think my experience of it has been helpful primarily with pain management. I'm not as convinced that it actually creates a physical change in the tendon, but I think that what it does do is it affects the nerve supply to the tendon and can help with pain management. So certainly, if you've got somebody who you're working with in terms of a strength program, a short course of ESWT can reduce pain for maybe 2-3 days, allow them to load a little bit heavier and get that stimulus into the tendon. So I think that my only caveat would be, if I spoke early on, if there's a single moment in the Achilles and there's significant high pain and loss of function, then you've got to be highly suspicious of a tear, and those are the ones that you should probably refer for imaging before starting ESWT. If they've had an insidious onset of pain with sort of pain levels 3 to 5, etc., then I think ESWT can be a great adjunct for pain management alongside your loading program.
Yeah, fantastic. Thank you. And I think that's quite useful for a number of people who might have not be in that professional setting, but a modality that they use for tendon injuries. Were there any of the other questions that you?
Just flicking through there. So I think somebody was asking about explain why to avoid compression. So I tend to try and keep things really simple for people, mainly because that helps me, but also for patients to understand. So tendons on the whole don't like being stretched or squashed. And you'll often see people with an Achilles tendon or a hamstring tendon stretching away the hamstring, the calf. And actually what that tends to do is just upsets the tendon, because it causes a compression of the matrix. When it's already damaged, it normally swells, and it doesn't like that compression, especially against a bone. So, that's why, for example, if we were talking about hamstring tendinopathy or glute tendinopathy, you would start them when they're in neutral to start with, so that they're not there with a flexed hip that's going to compress the tendon against it and aggravate. You'd load them in neutral to start with, and then as you get further along the line, you'll go from isometric neutral to more concentric eccentric at end of range, which is developing that ability for the tendon to be compressed and still work. So it's in the early stages when there's a lot of pain, and if you tell patients that, then they stop doing things like stretching their calf for an insertional Achilles, stop stretching the hamstrings for that insertional hamstring, and it helps settle the pain down and just reduces the load in the tendon.
Yeah, that's fantastic. Thank you.
A couple of other questions. So a question on Marfan syndrome. I think the genetic collagen and fibrinogen diseases are difficult. often these have to be taken very slowly. And in those early slides, I put up the metabolic tendinopathy. So you'll see an older patient who's not an athlete come in with an acutely swollen, really painful tendon. And with those, if you try and put them on a heavy, slow loading program, they're going to fail because their pain is way too high. So similarly, in the connective tissue disorders, we might start very, very slowly. It's just more about some capacity in the calf and the tendon. We'd be using pain relieving modalities, whether that's medication, injections, etc. And I think someone lower down talked about high volume saline. So I did toy around with this a few years back. Again, my concerns with a big volume is that if there is an intrasubstance tear, you can kind of open the tear out a bit more, but normally you'd see that when you're actually doing the procedure. So what I tend to do now is use a more moderate volume of local anesthetic and saline, and then I'll often use Ostenil on the ventral surface when you've sort of denervated the tendon, and then you can reduce pain with a bit more of a long-term sort of Ostenil barrier along the tendon. So in those metabolic tendinopathies, high levels of pain with lots of neovessels on scan, then that's a great option, although I don't use it very much in the elite athletes so much because they don't present like that.
Yeah, absolutely. Thank you. Thank you.
There's a little bit about training about hypertrophy, endurance, concentric, eccentric, isometric. I mean, I think hopefully what I showed in terms of the loading evidence is that isometrics can be variable, and although my colleague Jarrod is sort of like isometrics don't work, I do know a lot of athletes who use isometrics as part of their general warm-up if they're carrying a chronic tendinopathy. So they might, I encourage them get on the bike, just warm up, and then maybe do some isometrics before going into a pre-activation session to get that muscle firing. And definitely some athletes find that pain relieving, but it's not a panacea. I think with the Achilles, we use high force isometrics as part of the program. And then you've also got your seated calf raise, standing calf raise, where you've got a concentric, eccentric. Most of the good studies on loading, when you put the RCTs together, that always muddies the water. But I think, in my experience, if you're going to go with anything, it's heavy and time under tension is important. So if it's a rapid contraction, the muscle's going to be working hard, but that doesn't bring about a meaningful biological change in the tendon. You've got to go a bit heavier, a bit slower. Even a kind of 8-second 3-2-3 is still going to be quite effective at changing the cellular signaling within the matrix that then helps also promote collagen and promote repair, all those other things. So I think, there's more than one way to skin a cat. We tend to be fairly prescriptive about it in the early stages. And then as the pain is coming down, that's when you start to add in more running, plyometric type activity.
Fantastic. No, I think that's super useful and very transferable for people working either, again, in professional sport or with general population.
Yeah,
a few more flooding in, so I know I'm conscious of your time as well.
Yeah,
so
I've probably got about another 5 minutes. So
perfect.
Anyway, clinically be suspicious of a PVNS due to patellar tendinopathy. I think with PVNS, you normally get swelling in the joint. There's normally deep-seated pain, and there's normally an effusion, not always, but really that's something that we would see on an MRI. We sometimes do a gradient echo MRI sequence just to look for any evidence of that blood within the PVNS, and that can be helpful also, but that's where you really do need an MDT. Whizzing through them now. Omega-3, absolutely. So as part of the triple therapy, anti-inflammatory, doxycycline for its anti-TNF. I tend to prefer the EPA-based omega-3 rather than the DHA, which is the more common one to find over the counter. Elite Healthspan do a really good one, which is actually batch tested. So again, if you're looking after athletes who are using supplements, that's really, really important. What else have we got on there? What's most beneficial intervention? Early reactive patellar tendinopathy, and techniques discussed with time to return to play. Yeah, so I think again, patellar tendinopathies are really difficult because, like with any tendinopathy, often people can manage and still play their sport for maybe 3 months, 6 months before it gets to the stage where they can't. Even in the elite athletes, they can present with symptoms for 3 months that they've been coping with. I think in the acute reactive, I'd often use the medication just to calm things down. That can be really, really helpful. In terms of return to play from the surgery, I think the big game changer for us was, just having the faith to do a minimally invasive ultrasound guided debridement, because it used to be a real last roll of the dice, last chance saloon, open debridement, patella drilling, months of pain, very long period of time out. Whereas with this, we're getting some really good success in terms of early pain relief, early loading, and in our elite athletes, we're getting them back to return at 11, 12 weeks, which for a big surgery like this, I think is fantastic. So, we're hoping to collate all that data and publish a little bit later in the year. And already some of our surgeons who do that procedure are being asked to go and speak to other knee surgeons around the bazaars. I think that the biggest thing is that tendons are difficult, and they can be really chronic. I think the patient needs to understand that exercise prescription is not going to change the game really quickly. I always say it's a bit like an oil tanker that you've got to start turning, and then you just encourage it to keep turning. But if people stick with it, then a lot of the time they will make significant gains. They understand what aggravates their tendon, what allows it to recover, and then really just giving them load recovery, not on consecutive days, all the simple things really that allow that tendon to calm down and then progressively strengthen over a period of time.
Yeah, absolutely. Thank you so much. Well, thank you so much for your time this evening.
Pleasure.
No, it's been our pleasure. Thank you. We're just going to hand over to Andrew to do his final bits, and then
if anybody has any questions that I've not answered, I think my emails are on the slides. Happy for you to pass that on to your members. If they want to email me any questions, I can't promise I'll reply immediately, but I normally get round to it. Okay. I wish you all the best.
Thank you
Brilliant,
so much.
brilliant. Thanks very much, John. Appreciate your time for the Q&A.
Pleasure. Take care.
Thanks
Bye-bye.
very much for the recording. See you. Thanks. Bye.
Bye. Bye.